I'm excited to be able to share a little bit more with you today regarding some advancements for MTBIs and concussion and the brain rehabilitation arena. I do want to say thank you very much for Dr. Slininger for organizing this. And while I'm sad I can't be here in person, I am excited to be able to share more with you about some of the advancements in technologies that we're harnessing for neuroplasticity. I'm Dr. Emily Kalambaheti. I have a master's of science in clinical neuroscience. I got my doctorate doctorate of chiropractic from Palmer. I do have a diplomate on the American Chiropractic Neurology Board. I'm also a fellow in the American College of Functional Neurology. And most recently, I got my latest diplomate. I'm a licensed diplomate for the International Board of Quantitative Electroencephalography. I'm also the director of rehabilitation over at Genesis Brain Institute. So if you are in the area and you want to come check out some of the technology I'm going to be talking about today, feel free to swing by. We're just over by the airport, the TPA airport. So diving in, I wanted to share just the learning objectives. We're going to talk a bit about mild traumatic brain injuries or concussions, as well as the pathophysiology of both concussions and post-concussional syndrome. I'm going to review some of the evidence with you regarding the emerging technologies and the different modalities that we're utilizing, both for diagnostics and for rehabilitation, and then just explore the mechanisms and some of the limitations and applications of these different technologies. So let's dive in. I know this slide's a bit wordy. Just know that when you're talking about definitions, there's no way to do it without words. So I do have the definition up on the screen. According to the American Academy of Neurological Surgeons, a concussion is an injury to the brain that results in temporary loss of normal brain function. It can be caused by a direct trauma to the head. This is like if you fall and hit your head on the ground, or if you're working with patients that are survivors of domestic violence or assaults. But most of the patients will have concussions as a result of rapid acceleration and deceleration of the head. These are going to be the people that were either in motion and got stopped all of a sudden, or were stopped and got thrown into motion. Most likely from car accidents, although it can be from other sports-related events like a hard tackle, or even in children, sometimes the shaken baby syndrome, where the head doesn't have to hit anything, but the brain can hit the inside of the skull. When we're looking at codes for concussion, what's really interesting is that the ICD-10 doesn't focus on symptoms or symptom severity when it's coming to the codes. All concussion codes are going to start with SO6.OX, and then the last number 0 through 4 is just regarding how long the patient was unconscious for. If there's no loss of consciousness, that's just XOX, and then from there it goes up to 24 hours of unconsciousness. If someone gets a concussion and then is unconscious for 24 hours, it's not a concussion anymore. It's probably a moderate or a severe traumatic brain injury, so then you would use a different set of codes. All concussions are traumatic brain injuries, but not all traumatic brain injuries are concussions. Only mild traumatic brain injuries are considered concussions. That being said, in 2025, this year, there's been a lot of talk around changing the verbiage used in TBIs and getting away from mild, moderate, and severe. There hasn't been a consensus yet on what we'll be going to into the next year, but just know that people can have mild traumatic brain injuries, and it does not mean that their symptoms are mild. And some people recover fully from severe traumatic brain injuries with very few residual symptoms. So the mild, moderate, and severe don't always indicate the loss of function. They don't always indicate the severity of the symptoms. They just have other kind of defining factors that don't really give you insight on the patient, the human that's experiencing this brain injury. When it comes to MTBIs and concussions, 60 to 80% will resolve on their own without intervention. So when I'm talking about the technologies used in rehab, I'm talking about the rehab for the 20 to 40% of people that get a concussion and do not get better on their own. And just because they're going to get better on their own also doesn't mean we should shy away from documenting the concussion, especially in the world of personal injury. Documenting concussions and being able to prove that there has been a neurological insult's important, even if the patient improves on their own without rehab, because once you've had a concussion, you are more likely to have another concussion with less force, or to have the same amount of force cause a greater severity of injury. So I'm going to play a video. I'm just going to kind of talk through the video with you as it's playing. We're talking about concussions. One of the reasons that concussions can be a little bit difficult to diagnose is that people want to rely heavily on these structural imaging techniques like MRIs and CT scans, and you simply can't see a concussion on an MRI or CT scan because what's going on is happening at a cellular level. When you're looking at the brain and it gets shaken or there's that force, that acceleration, deceleration, because the densities of the white and gray matter aren't the same, they move at different velocities and the axons that are connecting those two get sheared. When an axon does get sheared, there's going to be intracellular injury, meaning that the inside of the cell can get damaged. When you're looking at what damage can occur, you can get the stretching of the microtubules, which causes intracellular damage, and then the creation of these neurofibrillary tangles. This will actually cause a neuron to have a more difficult time communicating with its neighbors. And then part of that is that once this cell is unhealthy, it's going to go into a low energy state, and then it's going to stay in a low energy state, and that can cause later on neurodegeneration if there's really severe injury or just a functional loss. So when a cell goes dormant or starts asking for less energy, it's going to continue to ask for less energy as a self-defense mechanism. The thought with that is that as the cell is injured, it doesn't know why it was injured, right? Like the brain's trying to help us and keep us safe without the context of what's going on. So this injury occurred, your brain's saying, you know what, this spot is injured, we're going to have less energy, and then we're going to give it less energy and give it less blood flow because I don't know if it's going to be injured again. And then your brain starts using other areas to compensate. And sometimes those kind of sick or dormant areas do re-trigger, like I said, about 60 to 80%, but 20 to 40% of the time, they're not going to reactivate on their own. And the key with neuroplasticity is the brain gets better at whatever it does the most. So if your brain's getting really good at being sick or really good at avoiding these unhealthy regions, it will just continue to stay sick and dysfunctional. If that occurs for 2 to 3 months, we now change that diagnosis from mild traumatic brain injury or concussion to post-concussional syndrome. Post-concussional syndrome has its own set of diagnostic criterion, its own ICD-10 code, F07.81. What's interesting is that if you get a referral from a neuropsych or like a sports neuropsychologist, they don't use these codes. The only code in the DSM-5 that talks about the effects of concussions and traumatic brain injuries is the major or mild neurocognitive disorder due to TBI. Once again, it has its own code. Just know that mild neurocognitive disorder is going to be deficits that don't impact their independence and activities of daily living, and then it's considered major if it does impact their activities of daily living and independence. Kind of going back to post-concussional syndrome, there's 5 main subtypes. You can see some research expand on these, but ultimately the main subtypes are cognitive, ocular motor, headache or migraine, sometimes referred to as autonomic, vestibular, and anxiety or mood. They're not exclusive, so it's not like if you have one, you don't have the others. And oftentimes I would say that your patients are going to have a primary and then a secondary or a tertiary or maybe a joint primary. What's extra interesting, though, is that all 5 subtypes will come with 2 concussion-related conditions: sleep disturbance and cervical sprain. So a cervical sprain or strain or cervical dysfunction, like neck injury, it makes sense, right? If your head got thrown forward and back hard enough, you probably hurt your neck. And if you hurt your neck to the point where you have disc herniations or ligament injuries or tendon injuries, then your head probably moved pretty hard forward and back or side to side or rotated, and your brain hit the inside of the skull and was also injured. So I would say when it comes to, these really advanced techniques or utilizing chiropractic care, we're going to see cervical sprains and strains day in and day out, cervicalgia, neck pain, dysfunction, limited ranges of motion. And if those patients had some sort of traumatic event and also have brain fog or also have blurry vision or also are dizzy or nauseous, you should be thinking like, okay, the neck's obviously injured. You guys are neck specialists, especially the upper cervical, like cervicals in your name. So being able to take a little step back and going, all right, if the neck was this severely injured, what happened to the brain? It's just sitting on this little stalk, if you will. So being able to say, all right, yes, there's cervical strain. What else? Is there also cognitive dysfunction? Are they also irritable? I get this a lot too, where the patient will be like, my neck really hurts, but I'm otherwise fine." And then the wife will chime in, "Yeah, except that he's super irritable right now, or that he can't remember where his keys are." Or had this one gentleman yesterday, um, he keeps leaving the front door wide open. The wife's freaking out. She's like, "We have dogs. He's never left the door open before." And he's like, "Oh, well, I'm just being a little extra forgetful right now. It's not a big deal." Well, it seems to be affecting your life. And it's a sign of cognitive post-concussional syndrome, right? So when we're looking at those 5 subtypes, once again, cognitive, you're thinking, focus, concentration, memory. Ocular motor, you're thinking eye movements. Headaches and migraines are just a symptom, but it's usually due to some sort of autonomic component as well. The vestibular system lives both in the brainstem and then extends out to your inner ears. A lot of people that have these vestibular subtypes will be dizzy, nauseous, motion sick, and have balance issues. And then anxiety and mood, exactly what it sounds like. Irritability, anxiety. Also look out for the patients that are commenting that, like, "I just don't want to be around anybody. I don't want to do anything." It can be fatigue, but those are also signs of depression, and getting them over to a mental health counselor can really benefit them long term. All right. When you're looking at the technology for concussion detection, right? Before you go diagnosing post-concussional syndrome, you're hoping that the patient came into you and you could diagnose the concussion. But the good news is these same technologies utilized for concussion detection can be helpful for identifying post-concussional syndrome as well. So I'm going to talk a little bit about pupillometry, or the measurement of the pupils, video oculography, or creating videos and graphs of eye movements, computerized posturography, or utilizing technology and force plates to look at sway patterns and balance, as well as quantitative electroencephalography, and that's looking at the electrical signals inside the brain, sometimes referred to as a brain map. So diving into pupillometry, that study that's referenced is a fairly recent study, just a couple years old, that was done with Professor Frederick Carrick, the father of functional neurology, and it looked at how we can use the pupillary light response and specific metrics involved in the pupillary light response to differentiate between people that have had concussions and have not had concussions. And what they found is that there's 5 main variables that allow for that differentiation or identification of, yes, there was a concussion, or no, there wasn't. So on the other side of the screen, you'll see normative data values. This is just for a patient of mine, 47, male, rear-ended, car pushed into the car in front of him, loss of consciousness, diagnosed with a concussion. But these are the normative values. So when you're looking at these variables, you're looking at latency. How long is it taking the pupil to start getting small when the light shines in the eye? How big the pupil was at its max, how small the pupil was at its minimum, how quickly it constricted, so how fast, or the max constriction speed. And then one of the ones that I think is easiest to understand is 75% recovery time. So if you're looking at latency of how long does it take for the pupil to get small, 75% recovery time is how long is it taking for the pupil to get to 75% of the size it was before the light shined in the eyes, right, before you did the pupillary light response. And when you're looking at latency, it's amazing how fast these reflexes work for you. It's a quarter of a second. So somewhere between a tenth and a quarter of a second is all it should take for your pupils to respond to light. Anything more than a quarter of a second is considered too long. Maximum constriction speeds measured in millimeters per second. It's a little hard. You're not going to be able to just look at this without an app. I do utilize an app. I have nothing to disclose on that front. But I utilize the PLR Reflex Pro. It's just an app that you can use an iPad for to get these numbers, which is nice because you can get a sense of the latency, but you're not going to get a sense of the maximum constriction speed. And then you can get a sense for the maximum diameter and the minimum diameter as well. But once again, the app does just put all the numbers on it. And that app was created after this research study showed that these variables help us make that decision of, like, yes, there has been a concussion, or no, there has not been a concussion. Pupillometry is also being used on the sidelines in a lot of professional sports teams because it's quick. It takes 2 minutes tops. And all the tech you need is an iPad, an iPad and a program. All right, looking at the eyes, I think it was Shakespeare that said windows to the soul. I can't really comment on the soul, but I will say eyes are definitely a window to the brain. When you're looking at video oculography, I do have just a single test on the screen. I'll play that video in a moment where we're looking at optic kinetics. But video oculography provides really good context of how the eyes are moving, how they're staying still, what they're doing at rest, and what they're doing in action. When you're looking at video oculography, one of my favorite ways to utilize this technology is by being able to see what the eyes do in the dark. You just can't see in the dark, right? So being able to put these fancy goggles on someone's eyes, put them in the dark, and then what do the eyes do when they're supposed to be resting? The instructions are just look straight ahead. And then what you'll see is nystagmus, a drifting and a bouncing of the eyes. Nystagmus will happen in 30 to 50% of concussions. And it's oftentimes, especially if it's there in the dark, oftentimes it might not be there in the light. That when they're in the light, they have the ability to fixate on something and suppress the nystagmus, but when they're in the dark, that nystagmus can really shine through and it can be pathological. So being able to identify a nystagmus if it's there. You can also look at pupil size in the dark and get that comparison. Most of my concussion patients are having anischoreas, meaning that one pupil is bigger than the other. And being able to document that is important as well. I also like using VOGs or video oculography to look at pursuits, all right, tracking movements, saccades, fast eye movements, as well as movement-based reflexes, the vestibular ocular reflex and the optokinetic reflex or response. So just playing this video, you can see that an optokinetic response is your ability to perceive things moving past you. It tends to get broken in people that are having car accidents where their cars are rolling or spinning, or when there's a lot of movement or jarring motion. So you'll see that this patient, they're trying to catch each blue stripe. And I have a specific way of prepping my patients for this test. I say we're about to have some bright blue and yellow stripes appear on the screen. Please keep your eyes in the center of the screen and your head still, and pay attention to each blue stripe that moves past the center. Try not to pick a stripe and follow it, and please do not count the stripes. Relax your eyes and keep looking in the center of the screen. And then what should happen is that your eyes should catch every blue stripe, right? And it should be a reflex. You shouldn't have to work hard for it. The same way when you're driving or maybe you're the passenger and all those trees are going past your car, you shouldn't have to think about the trees going past your car. It should be a reflex. You should be able to just enjoy the drive. But if you get motion sick, it's probably because this reflex isn't working well for you. So being able to look at the reflexogenic systems in the eyes, eye stability, especially in the dark, as well as these pursuits and saccades, all give you good insight on brain function. We also utilize computerized posturography. So this is just a fancy way of saying balance testing. I do like doing pretty elaborate balance testing, though. I put on the screen there the standards called a modified clinical test of sensory integration and balance. And it's 4 20-second long tests with the eyes open on a hard surface, eyes closed on a hard surface, eyes open on a foam surface, and then eyes closed on a foam surface. I will say I do like going a little bit beyond that and doing a cervical challenge, and I'll then, after these 4 20-second tests, do 10 10-second tests with the heads in different positions so that we can look at the cervical component of balance as well as some more vestibular components. So I'll do chin flexed, head extension, looking left, looking right, tilting left, tilting right, and then all 4, so anterior canals left and right, and then posterior canals left and right as well. And then once you've done those 14 tests, you should know what's going on in your patient's balance. Is it that all their balance is bad, every single test was poor? All right, well then you're probably looking at either 1, they just have performance anxiety, which is a factor, or 2, you have multiple systems at play here. But usually what happens is they might have really good standard balance, eyes open, firm surface or a solid surface, but then when they close their eyes, they have a big dip in balance. That kind of lets you know that when they try to rely on their proprioceptive systems or the vestibular systems, that it's not well for them. Sometimes you'll see the opposite, where actually closing their eyes makes their balance better. And that's usually because the eyes are feeding poor information into the brain, right? The brain's getting inaccurate information and then creating an inaccurate response. Sometimes, though, when their head's at neutral, their balance is great, whether their eyes are open or closed or on a hard surface or a foam surface. But when you start moving the head, you'll start having abnormalities in balance. And that can be indicative of cervical sprain strains, improper alignment of the cervical spine, poor muscle tone in the cervical musculature, or if chin tucked, chin flexed, or flexed and extended, not big issue. But when we start activating maybe a specific canal, right, the semicircular canals in the inner ears, that would be indicative of maybe a vestibular issue. So that's where you can take something as simple as, a Romberg's, where someone's just standing there, eyes closed, and seeing if they sway, and then using technology to really ramp up the amount of data you're getting so you can be that much more precise in the care that you're providing. All right, now going into QEEG. I'm excited to talk about QEEGs, mostly because I've been studying it for the last couple of years, and I finally got through my board examination this year and got that diplomate. But I'm also excited to talk about it because I really feel that this is one of the neuroimaging techniques that we're going to be seeing more and more for a couple of reasons. One, it's not invasive. There's no contrast used. There's no radiation used either. And then people don't have to be in these confined tight tubes where, their PTSD and claustrophobia are through the roof and they have to pop a Xanax just to take an imaging technique. QEGs are nice. They're free to move their arms and legs while they're doing the test. We do ask them to stay still. You put a cap on their head. I utilize a 19-channel QEEG. That's the most common one that you're going to see, but it looks at 19 regions of the brain, and that's what the research is using as well. So I do rely heavily on the research from Thatcher, Dr. Robert Thatcher. He's a PhD. He actually lives in Madeira Beach. He's just like 20 minutes away from here. So being able to look at the NeuroGuide database, he worked with the National Institute of Health to create a database of almost 10,000 people of what a healthy brain should look like. And then you get to compare your patients to these databases to say, compared to other people, your gender, your age, your handedness, do you have too much or not enough activity? Do you have elevations or decrease or depressions in power? How's the coherence of that communication in the brain? What was really cool is that the research that they've published does show that they have a 96.4 accuracy in being able to distinguish from mild versus severe traumatic brain injuries. It correlates with their test scores as well as their coma scores. And overall, the implication here is that QEGs can reflect the degree of brain network disruption. So when we're talking about cues, just know that we're looking at the electrical activity in the brain. And kind of when we talked about earlier, when those axons get stretched and the intracellular damage occurs, they start asking for less energy. Well, any cell with less energy is going to create less electrical signaling, right? Because you need the energy to create the electrical signaling. So you can actually map out the areas of the brain that are under-functioning or underperforming, and sometimes areas that are overperforming, right? They're compensating for these underactive areas. And you can just see these show up in the QEEG. That's one of the reasons why it's called brain mapping sometimes, is because you can get a map of the brain, which areas are hot or overactive, which areas are underactive, which areas are having too much expression or not enough expression. So let's look at some visuals. I do have a little video here. This looks at what I get to see when I'm looking at a QEG. On the left side, you'll notice the squiggles. Those are the actual brain waves. There's 19 channels. There's actually 20 because I do a linked ears montage, but the 20th channels are just the ones on the ears to make sure that we're filtering out head movements. But you can see which brain regions are over and underactive. When you're talking about QEEG and concussion, what the research shows is that people will have, and they don't have to have all of these, but these are some of the things I look for. Too much slow wave activity. This will make you feel foggy. These are the patients that are saying, I know their name. I met them yeah, Robert. Okay, yeah, I know their name, right? You can get there, but it's like pulling your thoughts through molasses. The other thing that you can see is just not enough fast wave activity. So depression of the beta waves. And what that'll feel like is like, I can do what I need to do, but I just can't multitask. If I can just take things one thing at a time, I can probably get through it. But high levels of function, like deductive reasoning, multitasking, are going to be much more effortful or just full of errors because they're not having this nice, fast, rich beta wave activity. So too much slow wave, slow being theta and delta, not enough fast, thinking beta, or the third thing that you might see is the switching of a posterior dominant alpha to a frontal or an anterior dominant alpha. This only occurs with eyes closed. I do most of my analyses with eyes closed just because when people's eyes are open, they're suppressing their alpha wave activity, and then they blink And then every blink generates muscle electrical signals that interfere with my data. So I usually just do my analysis off of eyes closed. But what you should see is that the alpha wave activity should be mostly located in the back of the brain. And alpha wave activity is a good indication of the thalamocortical rhythms, or how the brain is communicating through the thalamus, or the body through the thalamus to the brain, right? So what normally happens is that it's kind of in the background. You're not thinking a lot about it. And then you get a concussion. And now that kind of, it's not truly reflexive, but kind of that out of sight, out of mind. How is the brain functioning? How are we perceiving our world? How are we perceiving our bodies? You know, we're taking in all this sensory information, and you don't have to think a lot about it most of the time. Well, now it's shifted to the front part of our brain. Now you have to think about it if you want to perceive it. And that is exhausting. It also makes it harder to use your frontal lobes for what they're supposed to be for, which is good motor coordination, reward processing, consequence processing, decision making. So these are patients that are going to can have some cognitive challenges, some coordination challenges, and then it's just very tiring to have something that should be happening automatically now take all this volitional effort. So when we're looking at the QEGs, too much slow, not enough fast, and the switching of alpha from a posterior to an anterior dominance. You'll also see things like coherence readings change. Coherence is kind of like when someone's speaking coherently, you can understand them well, but someone might be talking so fast that it's almost gibberish and you can't really understand them, or so slowly, or they're skipping words that you can't really understand them. So when you're looking at coherence, there's a Goldilocks zone. And then if you have too much, it's called hypercoherence, or not enough, it's called hypocoherence. And you'll actually see either of those in concussion. A lot of times, though, you'll actually see hypercoherence, like too much. And it's because the brain's trying to reorganize itself. It's just had this injury. It's trying to do all this crosstalk to figure out how it's going to function. So you'll see these hypercoherence readings as well on the QEEG. Very good. All right. We've just diagnosed a concussion. We've talked about their pupils, their eyes, their balance, their brain waves. Now, what are we going to do about it? There are tons of ways to rehab concussions that don't require technology. I will say, though, we're here to talk about technology today. So I'm going to go into some of the high-tech things that I utilize on a daily basis to help my patients recover from concussions. And just know, it's not that all my patients get all the things I'm about to talk about. It depends on their symptoms, who they are as a person. And then there are some limitations for a couple of these technologies where you just can't use them for certain types of patients. So we'll talk about that together as well. First things first, hyperbaric oxygen. Hyperbaric oxygen therapy involves putting someone in a closed chamber, pressurizing them inside the chamber while they breathe in extra oxygen. The mechanism of action is normally you breathe in oxygen, and then each of your red blood cells can carry 4 oxygen molecules, right? And then they have to move through wherever your circulation's taking them. But we had talked earlier about how there's some regions of the brain that when they're damaged, they ask for less blood flow and ask for less energy because they're in that dormant state. Well, if an area is asking for less blood flow, it doesn't matter if your pulse ox says you're at 100%. If you have poor circulation, you have poor circulation. Gases under pressure, though, can dissolve in a liquid, right? Like the soda can, right? You can just pressurize the soda can and dissolve the carbon dioxide inside the actual liquid. Well, we're just big soda cans. So we can pressurize ourselves in these hyperbaric chambers while we're breathing in extra concentrations of oxygen, and the oxygen will just dissolve in the liquid portions of you. So in the blood plasma, and then the cerebrospinal fluid, right? The brain is bathed in this rich liquid. Well, we can make that liquid richer with more oxygen using hyperbaric oxygen therapy. What can occur with that is that you get increased oxygen delivery, you support the mitochondria and their ability to create ATP or cellular energy, and then you get 3 things that I love: angiogenesis, neurogenesis, synaptogenesis. So genesis just means creation of new blood vessels, angiogenesis, creation of new neurons, new brain cells, neurogenesis, and then creation of new connections between those neurons, or creation of new synapses, synaptogenesis. That's a win-win-win for people that are having brain injuries. I also like HBOT for people that have brain injuries because of a stroke, where they did have disruption of blood vessels, especially like ischemic strokes. You can just create new blood vessels to route around those areas of damage. What we see with our patients, though, is that once you get the hyperbaric oxygen therapy, you've just fueled up. So what are you going to do next? It's kind of like, okay, you just took your pre-workout and your protein. If you don't go work out, you're not going to get stronger. You can drink as much protein and take as much pre-workout as you want, but if you just do that and then lay on the couch, you're not going to get better. So once I've fueled them up with their hyperbaric oxygen, I put a little laser over their head and I direct that oxygen or direct that blood flow where to go, utilizing transcranial photobiomodulation. So the mitochondria have these little components inside of them called chromophore Cs that can actually take packets of light energy, which we call photons, and turn it into cellular energy. It's amazing. It's kind of like we have photosynthesis, but unfortunately we do a really bad job of it. So we only have it for very specific wavelengths of light, and they're not wavelengths of light we just get from the sun. Unfortunately, we're not like Superman where the yellow sun just fuels us up. So we have special lasers that utilize red and near infrared light to stimulate those mitochondria to increase more energy production, or ATP, and ultimately decrease oxidative stress. And the research shows, and that's where like all this is research-based, improvements in cognition and sleep. There's actually a really cool study. We're doing it over the right frontal lobe, helps with working memory, even in people that have been healthy. So that's a pretty cool research article. I like using their QEEGs to tell me which areas of the brain I need to put this laser over. You can also use MRIs if there's really big structural damage to tell you where to put this laser, but I like using the QEEGs because obviously I'm doing those in-house. There are also different photobiomodulation devices that are just kind of whole brain, they're like full helmets. Those are nice too, but if you can be more specific, shouldn't you? And I feel like you're the kind of crowd that's going to get that, right? If you can be more specific, let's be more specific. But I know that's, I don't have to harp on that. All right, so we fueled them up. We gave them oxygen. We increased the blood flow to the regions of the brain. Now let's do our active rehabilitation. Vestibular rehab is an integral part of a lot of concussion rehab, especially when they have vestibular post-concussion syndrome. These are patients that are dizzy, that have balance issues, and what you'll see is that with vestibular rehab, they'll have less dizziness, better balance, and then usually less nausea as well. Whenever you're having vestibular issues, nausea can go hand in hand with dizziness due to how there's an integration in the middle and lower regions of the brainstem. But I digress. Vestibular rehab can be super high tech. I've worked at practices where we have these chairs, we strap them in, we're flipping them upside down, and then I've had practices where we're just looking at dots and we're turning their head. All right. The one I have right now, though, that's on the screen is a weight shift targeting, where they're actually using their proprioception and their vestibular system to move their body and shift their weight utilizing a neurosensory integrator. So you can go very high tech, very low tech, but vestibular rehab is a part of a lot of my concussion rehab programs. I also utilize transcranial magnetic stimulation. That's me. I use it on myself. I don't actually use it on myself, but my team uses it on me because I want to have the best brain possible. You know, if I'm going to be a brain specialist in the chiropractic field, I've got to have a pretty darn good brain myself. TMS was originally FDA cleared in 2008 for depression, so depression that doesn't respond to medications. Since then, though, there's been a lot of other research that's been published, mostly outside of the U.S., to be honest. I did my TMS certification through the University of Maastricht, which is over in Amsterdam, and I will tell you, over in Europe, they're using TMS for so many more things than just depression. They're using it for Alzheimer's and Parkinson's and traumatic brain injuries, and the preliminary studies have shown improvement in both cognition and mood in patients with TBI. So while I can use TMS, and we all can as chiropractors because it's considered a non-invasive electrical stimulation, I do also have a psychiatric nurse practitioner and a mental health counselor on my team at Genesis Brain Institute to prescribe the TMS, especially for those that are just having mostly depression or suicidal ideations. The way it works, though, is that magnet, you see how it kind of makes like a figure 8? It's overlapping electromagnetic waves, and where those waves overlap is where the stimulation is occurring. So you can just force an area of the brain to turn on, or you can actually force an area of the brain to turn off, depending on if you're using a high frequency or a low frequency. Don't worry so much about that, but just know that we have the technology to say this part of your brain isn't functioning well, I'm going to make it turn on. And the good news is it's pretty painless. It's a little annoying. It's kind of like a toddler tapping your head over and over again, where it doesn't hurt, but it's not like I don't like fall asleep during it. But for most of my patients, it's very much worth it because it helps them feel like they're waking up for the first time. And then one of the side effects, if you will, of TMS that I get is that I sleep so much better. Like waking up before my alarms, waking up before my dog. That's how you know it's working well, is when you get up before your dog wakes you up. But we utilize repetitive TMS, meaning that it's not just one treatment. You have to keep coming. But we can do that for the mood aspects as well as the cognitive aspects of TBI. There is a limitation with transcranial magnetic stimulation. You do not get to use it for anyone that has seizures, and post-traumatic epilepsy is a big component, right? So when you're looking at people that have had traumatic brain injuries, they're like 50 times more likely to develop a seizure disorder later in life. Sometimes they'll have seizures right after their head injury. Sometimes it's years later. I have a patient right now that I'm treating that it took him, I want to say like 6 months to develop this post-traumatic epilepsy, and that's his biggest symptom. So you can't use TMS for people that have epilepsy. You also can't use it for anyone that has metal in their skull or anyone that has implanted devices like pacemakers or baclofen pumps or bladder stimulators or spinal cord stimulators. Other than that, though, it's pretty safe, very effective. All right, we also have neuro and biofeedback. Biofeedback, the kind of just breaking down the word, is giving you feedback on your biology. We utilize heart rate and breath rhythm biofeedback. In the picture on the screen, you can also see that we're using VR, or virtual reality. I only use VR for patients that have good optokinetic responses. If you don't have good optokinetic responses and then you put yourself in a fake moving environment, you will get nauseous. They call it being cyber sick. It's like motion sick, but when there's no movement. So I only use VR biofeedback for patients that have good eye reflexes. Otherwise, I'll just use normal biofeedback where they're just looking at a screen. So they'll have a little thing on their finger monitoring their breath rhythm and their heart rate. And then as they're calming down their heart rate and breath rhythm, they get to watch some sort of visual on the screen that's giving them feedback on how well they're doing. You can also do that same mechanism, but instead of heart rate and breath rhythm, do brainwaves. We call that EEG biofeedback or neurofeedback. So neurofeedback involves putting a couple of electrodes over the scalp on those brain regions that we saw were over or underactive, and then rewarding them by having them get to watch a TV show and control that screen brightness with their brain. And every time the brain is using those brain waves in a regulated and healthy manner, the screen's on. They get to watch TV, or they can listen to music. If they're visually sensitive or screen sensitive, they can just listen to music. And then as their brain tries to fall back into those bad habits, the screen will fade to black or the music will turn off, and their brain will want to get that reward again. It wants that dopamine of getting to watch TV, of getting to listen to music. We all know that watching TV and listening to music make us feel good, right? We get a dopamine burst. So then the brain will start figuring out how it can turn back on these pathways or regulate these brain waves to get the screen back on. And then once the screen's on, the brain gets rewarded. And then over time, you're strengthening these pathways, these reward pathways of like, oh, it's best when I have better regulation of these brainwaves. And the good news is that these regulated brainwaves tend to be more efficient. It's not efficient to have certain areas of your brain not working in a healthy manner. And your brain loves efficiency. So once it realizes, oh, one, I get rewarded. I've been getting rewarded for the last couple of weeks. And now I'm realizing these pathways are more energy efficient. I'm able to process information more efficiently. It'll start using these pathways reflexively, or kind of unconsciously without a lot of effort. And that's where the training in the office turns into real life gains through neuroplasticity and creating long-term potentiation. So the research shows that the heart rate biofeedback improves executive function, emotional processing. Neurofeedback is a little less research than biofeedback, but especially having improvements in mood and anxieties. The other thing, too, is a lot of my patients do have PTSD, especially if their concussions are because of a traumatic event, like an assault or a car accident. And you can utilize bio and neurofeedback not just for their concussion symptoms, but also their PTSD symptoms. So it's really a win-win. All right, from there we have the vagus nerve. I'm pretty sure you guys all know about the vagus nerve. Cranial nerve 10, my favorite cranial nerve, starts in the lower aspects of the brainstem, go down past your neck, lives right next to your carotid artery and your jugular vein. That's how important it is. Goes to the heart, then into the intestines, right? It's a great wanderer, the vagabond, if you will. And you can do vagus nerve stimulation by implanting an electrical device, or you can just use one of these handheld devices. We utilize the Gamma Core at my practice. I have some patients use like Hulist or Truvaga. I'm just excited to be able to activate the vagus nerve in such a direct way. You can activate the vagus nerve without electricity by gargling and humming, slow, deep breathing and meditation. But the issue with that is that the people that are already in that fight or flight, strong sympathetic dominance, like it's like trying to tell someone who's depressed to just like be happy, or telling someone who's anxious to just calm down. Like it doesn't work. Their brain is having abnormal signals. Like you can't just tell them to calm down. So the language of the nerves is electricity. That's how one nerve communicates to another nerve. Electrical signaling causes a chemical cascade that causes electrical signaling. So we can just use electricity. I like doing it over the neck because 99% of the vagus fibers will go through the neck. There are some vagal nerve stimulations that'll be on the ears, the auricular components. Only 1% of the fibers go to the ears, so I would prefer to use the 99 over the 1. And I do have patients that utilize the vagal nerve stimulation for their concussions and then end up getting it afterwards for other symptoms as well, because it's better to be in that nice rest and digest and recover state. So when we're talking about the vagus nerve, we're talking about parasympathetic activation. And what the studies have suggested is that it improves mood, improves cognition, and decreases headaches and migraines. It's a win-win-win. It does help modulate that autonomic nervous system, and then better parasympathetic stimulation can actually improve neuroinflammation due to a vasodilation and better circulation. So being able to activate that vagus nerve in whatever way you so choose or the patient so chooses, I would just support vagal nerve stimulation. The only patients that you should be worried about for the vagus nerve is if they have electrical planted devices. Using electricity is usually contraindicated in people that have implanted electrical devices. And 2, if their heart rate's already very low, usually vagal nerve stim will actually lower it a little bit more. So just be careful if their heart rate's really low. But I actually use vagus nerve stimulation for my autonomic post-concussive syndrome patients that have dysautonomias after their concussion as well. And I'll do vagal nerve stim while they're going through different orthostatic challenges. So going from laying down to standing while activating that parasympathetic nervous system, either at the vagus nerve on the neck or the trigeminal and hypoglossal on the tongue. All right, biggest takeaway, I don't use all of these for everybody. It just depends. It depends on who they are as a person, their medical history, depends on what their symptoms are, their areas of dysfunction. You'll occasionally get a concussion patient and their QEEG will look pretty darn good. So that you know what I'm probably not doing with them? Neurofeedback. Sometimes you'll get a patient where they don't have any mood issues. Well, then I'm probably not doing TMS. And sometimes you get a patient where autonomically they look quite good, so I'm probably not doing vagal nerve stim. So it just depends on what your patient needs and also their preference. Some patients don't want to do TMS. Some patients don't want to do hyperbaric oxygen, especially if they have claustrophobia. That's okay. Some people just can't do some of them. I know for hyperbaric oxygen, COPD, like if your lungs just aren't healthy enough to handle the pressure, then you just can't go into the chamber. And that's okay. Every brain is unique. Your brain is as unique as your fingerprint. So if you have a brain injury, your brain injury is going to be just as unique, which means your brain rehabilitation program should also be just as unique. When I was talking today about the technologies, just know it's not the end-all be-all. There's so many ways to help patients get better and to help their brains get better too. Finding the right tool sets for you and for your patients is part of having a practice. And then sometimes it's not just about what you have, but who you know. So I'm not an upper cervical chiropractor. So I'm very glad that I know Dr. Slininger, so I can send him my patients that need what he does. And he might not have a hyperbaric machine. All right, so send him my way. Part of that referral process is making sure that your patient gets what they need, even if it's not with you. And that's okay. I joke sometimes that I'm a specialist. which means every other specialty is not my specialty. I have my one specialty, and it's the brain rehab components. You know, a lot of it does involve technology, but if they need something else, I'm happy to send my patients to my fellow chiropractors and other members of the care team as they need. If you do want to learn more, feel free to shoot me an email. It's just dr.emily@Genesis Brain Institute. If you're in the area and you want to schedule a tour, email me. Come by. Let's see the technology in use. And if you have a patient that you think might have benefited from some of the technologies I mentioned today, feel free to send me a referral. I have very little ego. I'm happy to share patients. Whatever our patients need to get better, I'm there for them. So just want to say thank you so much for your time today. I appreciate you allowing me to present virtually, and just send another shout out to Cerebral Chiropractic Clinics and Dr. Slininger for organizing and working on this amazing event today. So thank you very much for your time.